Good morning and welcome to the Ambulance Service Oversight Committee, and we will call the meeting to order. First on our agenda is any announcements that anyone might have. Okay, hearing none. We didn't have a quorum at our last meeting, so we have two sets of minutes that we need to approve. So first would be minutes from the May 10th meeting. Can I have a motion of approval?
Move to approve Dirksen.
Second, Meyer.
Okay, we have a motion and a second. Next would be the minutes of the August 9th. If we could get a motion for those.
And I'll move to move. There we go.
All right, second.
Second that.
Okay, thank you. So then we would go on to the data review, response time, transport destination.
Good morning. The 3 months of data are there. Everything is largely consistent. No big changes there. In the August get-together, we mentioned that July had been our busiest month ever, and we evidently are in the mode of setting records because September far exceeded any other month this year, just as far as a volume standpoint. As far as destinations and dispositions, that runs largely consistent. Consistent across the 3 months. Our highest call types are abdominal pain, alcohol use, and behavioral psych. So continuing that trend there. Response times, the 3 months, just overall, they're 97.45%, 97.59, and 97.5. So those are all well above that 90 or 92% goal. And September just at 97.59, being the busiest month. It's kind of nice that that was our best month on response times too. The crews felt the pinch and the pain, but it was busy, but things got taken care of. So I'd entertain any questions you have on the data that's in there.
Jason, just having been seeing this report now for several years, I see a lot more reasons for elongated response times. You just attribute that to the busyness and.
As far as a lot more reasons?
Yeah, I mean,
I
I kind of remember when we first started this, there was probably maybe 3 a month or something, or 4, and now that there's more, and I'm just.
Yeah, I think looking at that, I don't personally do the response times data. That's another member of our organization. I do the clinical data, but looking at those data back to 2013, 14, 15, those volumes were pushing a quarter of what they are now. So I think Sherm used to cover this a bit when he was in Tim's role, but we go for a unit hour utilization goal of about 40% is kind of what we have dialed in for what we need. And so as you have more calls, as things grow and expand, you're gonna naturally have a couple more response times exceptions, but from the percentile, like I say, the goal, Sherm, Tim, Rick, someone help me out, is it 90 or 92%?
What the goal is?
The national goal?
90%. 90% is the, yeah.
So we're, I think we're still.
Reaching calls within 8 minutes, 59 seconds from the time of dispatch.
You look at that and as, if you see consistent trends in that getting there, or dipping into that number, that's when crews get added, but still achieving a very high level of success with hitting them. It's volume driven.
Yeah, and Tim Meyer and I have been, we have a plan to add crews that we're working through right now for the next fiscal year, which will start in January. If we need to pull the trigger quicker, we would do that. I don't know that the data, I feel the data doesn't quite support it yet, but we're very close. And then typically what we do is we'll look at where and when the calls are occurring in addition to just response times. So we want to make sure that the crews are deployed appropriately. We use what's called system status management to help us determine, it really is a computer algorithm that looks at historical call volumes and where they occur. And we have a predictive analytic tool that actually shows us where we should be placing our ambulances based on historical call and run volumes and where they occur. So we do that, and then sometimes we shuffle. We've done this several times in the last, well, ever since I can remember. We will move our shifts around. So if we're busier, for example, at 2 o'clock in the afternoon, we would add, that's where we would put that new team on. And we might adjust it hours, you know, a few hours each direction, again, based on that predictive algorithm. So, yeah, there's a lot that goes into it. You don't just put another crew out there willy-nilly and say you're gonna work 8 to 5. It doesn't work that way in EMS work and, well, in public safety work in general. You put them on when they are needed. If it told us that we need to add another crew on a Saturday, that's what we would do. So, hope that helps a little bit.
And if construction would ever end
Yeah, right. The road construction
off
factor.
this year.
Absolutely. No. And that's what I was expecting, that was there on some of those issues, and it's just good for us to talk about it and make sure that we're understanding where everybody's at and the concerns that we have in our community, making sure that we serve each other. We have the same issue with the fire department, with construction and getting around and getting to places. And, you know, the good thing is there's a tiered response within our system that we really provide a good service that way to the community. So.
We did move a truck out there on 52nd Avenue during the intersections and all that kind of stuff too, so it's tough.
Absolutely. Thank you.
Just cranking quick numbers, one of the lowest months was 796. If my math skills are up to date, and this September one was 1291. So 800 to 1300 call difference, or, you know, 50% bump.
Question. Sherman and I were just talking about the behavioral health, psychiatric issues that we're seeing throughout the community, and it's always the first, either the number 1 or number 2 on your calls here. Is this all RIG calls, or does this include like mobile crisis unit type of thing, or?
This is just calls that are triggered through a 911 response or initiated from a 911 response. So 911 call where we get dispatched for it. Having said that, I think we see some differences in the destination. The mobile outreach program has been huge about people not taking unnecessary trips to an ER and alternative disposition type of things. But behavioral has historically stayed at the top.
I think a huge asset has been the mobile outreach program. That has taken a lot of calls.
But it's still
high.
It's still high, and I just look at all the rig time we're taking up, where that translates into increased response time for medical emergencies. And I mean, at some point, do we have to look at something or adding on to the mobile crisis unit?
I think that certainly can play a role. You know, it would obviously just, depending upon what else is going on at the time, but I mean, behavioral health, we ran this data a few years ago, Jason. Remember when we looked at how long does an average behavioral health call take? And it does take longer. I don't recall, that'd be something that might be interesting to look at again, but.
Yeah, I'd have to dig into that one.
I know, that's a tough one.
What I can say as far as the shout out to the MOP program, or mobile outreach, is that our percent of transports for behavioral health type calls is way down.
Yes.
They're getting more to the place that's the best appropriate decision for them. So I don't know if that's looking at something as far as where it goes from the 911, you know, when the call initiates there. So I think the problem hasn't gone away. We've just found some better efficiencies as far as how to deal with it, not clogging up the healthcare system when that incident isn't an ambulance or ER type level of need. A lot of things with mobile mental health crisis response teams that get patients aligned with what they were ultimately looking for without having to go through law enforcement, through us, through the ER. We can get them directly to that from the field. So I think we're seeing a better disposition in the end, but the volume of it happening isn't changing.
Any further discussion on the data review, or if not, we'll move to response times?
I'm sorry, I thought I hit that in the last one.
Okay.
Up in that 97.5, give or take 0.1% for the last 3 months, so all of them are above that 90% goal. Well above it, despite our busiest months.
And anything further on the transport?
Transport destination, no changes. I mean, it sits where its normal thing is. The vast majority is patient-driven. Outside of that is protocols that we work on in conjunction with all of the facilities in town. But yeah, it's overwhelming is patient choice, nothing jumping out there.
And I do need to, since I'm kind of new to this official chair role, I did fail to call a vote on the minutes, and no one pointed that out to me. So if we could just circle back to the May 10th minutes and just do an all in favor?
Aye.
Aye. Any opposed? And then also for the August 9th minutes, all in favor?
Aye.
Any opposed? Thanks for being gracious to me.
Buddy check.
Any other updates, issues that anyone else has? We do have included the 20 meeting schedule in your packets. We are going to do a little bit of checking on to the actual bylaws, things like that that are required for the meetings, just to see if there's some adjusting that we need to be doing. I know historically these meetings have been a little short lately, so we're gonna see, you know, what we need to do for requirements of meetings, and then if there's other agenda items we would need to look at adding for future, all of those kinds of things, so we will keep you updated on that. Otherwise, any other business for this morning?
Probably just, Tim, whenever we want to be ready to kick in the winter response, as we start to see the temperatures dip over the next couple of weeks, we changed our response protocols a little bit, so whenever you guys are ready to trigger that, make sure you let us know. We'll be ready to kick that up.
Will do.
And our next meeting at this point is scheduled for February 14th. And if nothing else, is there a motion to adjourn?
So moved.
Second?
I second.
Thank you all for coming.